Let's go ahead and get started on the webinar today, Meeting Patient Needs Across the Continuum of Care. Thanks again for dialing in. I'm Greg Fulton, your moderator today. Housekeeping, every webinar you've been on, we will say that the recordings and slides will be sent out to you and everyone who registered here today. We will be saving some time at the end for Q&A. You see your chat box, or you see your question box. Please do send your questions in at any point throughout the webinar. We've got folks monitoring in case we have any trouble with sound, things like that, but feel free to let us know if you have any issues in that regard also. Won't spend a lot of time preambling. We've got a couple of great speakers and a lot of slides to get through today. And again, want to keep a lot of time for questions. So let's take a look at our speakers and we can let them get started. We do have a Cynthia and a Cindy here today, but we will keep them straight. Cynthia Burghardt will lead us off first here. As you see, she's Research Director, Value-Based Healthcare IT Transformation Strategies at International Data Corporation. We all know them well as IDC. Our next speaker, in chronological order, yet they will certainly be talking amongst themselves and handling questions together as well. Cindy Gaines, MSNRN, you see there. She's the Chief Nursing Officer for Population Health here at Philips. Side note for Cindy, she's been with us for about 6 months or so, or within that time frame. Prior to that, more than 20 years in on-the-ground clinical experience in nursing and executive nursing and admin roles at various health systems. And so a lot of real clinical background, and between the two of them, you get a real good look at all sides of the equation and clinical relevancy as we get started here on the webinar. A lot of jargon in this industry, care continuum, population health, precision medicine. Where does that all stand through? Analytics, risk, frequent flyers. How do you focus on those patients, yet not forget every patient? That, I think, is the new way, really, to start looking at it today, whether you're in VBC contracts, private payer contracts, really just looking at your outcomes. I'll stop at that and let our speakers get going here today. Cynthia Burghardt will start us off, and thank you all very much.
Greg, thank you very much. And as Greg said, good morning or good afternoon. Thanks for joining us. I think there's one thing we can all agree on, which is there's no silver bullet to solving the healthcare challenges that we face, although with the upcoming political seasons, they're bound to be, and there already are many pundits out there talking about how to solve it. But there are a couple things that we actually do know. We know it's too expensive. We know it's inconvenient. We've all had that experience as patients ourselves. It lacks continuity, it lacks personalization. And all of those factors end up being really drivers or barriers to receiving care. If you know it's going to take you 3 hours to make and sit through a doctor's appointment, you may not do it if you're a full-time working individual. And we know that when people avoid healthcare, their health typically gets worse. So one of the things that we're going to talk about today is these factors that contribute to poor health. I'm going to talk about moving healthcare across the continuum. Historically, healthcare has been very institutional based. It's been based on the needs and requirements of physicians and hospitals. My primary care doctor's office is open from 8 to 4, and they take an hour off for lunch. Not really very helpful in terms of getting care and services. We're going to talk about the increased adoption of digital technology, both by consumers as well as by providers on behalf of their patients. And that to me is one of the really encouraging parts. What we need to do is learn how to effectively use them. And then finally, as a technology analyst in healthcare, I'm going to talk about the underlying infrastructure that's really needed to create that infrastructure so that we can deploy those devices and make sure we have the right patients and so forth. So let's start talking about kind of the drivers of change. Why is this happening? So there's cost and quality pressures. That's not anything new. We tend to choose the most expensive care historically because we didn't have the information to know any better. We thought sending someone to a skilled nursing facility after hospitalization was the right thing to do. We didn't really look at the cost piece of it. We also just talked about how inconvenient healthcare is and how it really lacks convenience and consistency. And there's some pretty significant impacts of that. We looked at the non-adherence to care plans for chronic patients. And it's estimated that costs us roughly $100 billion a year. Missed appointments at the National Health Service in the UK, $1 billion a year for missed appointments. Simple reminder can address that particular issue. So, and then we have the increased acceptance of the use of connected devices. In a survey that we found, it's estimated that 95% of Americans have a cell phone. About 77% of Americans have a smartphone. So the technology is there. We're also going to talk a little bit about some data that we have on medication adherence. So let's go ahead and move on and talk about kind of the role of whole person care, the whole notion of adding in social and human services, looking at the patient in their totality. We know that the delivery of clinical care is really only a piece of what drives health, and that other factors such as food insecurity, housing insecurity, lack of transportation are all barriers to health, barriers to care. We first started taking a look at the social determinants of health from a data point of view. We're beginning to learn how to use it as a predictor, understanding drivers, and then the next step is really what are the services that payers and providers are offering. And we see from survey data that IDC produced back in February of this year, 50% of providers and 40% of payers are providing some level of social and human services. When we dig into that, what we found is it's really about referrals. It's not that they're actually delivering those services, they're helping to arrange those services. And one of the things we need to start thinking about is how can we automate the how we create the connectivity so those referrals are easier to be made and they're more effective. So we start to see the growth of companies like Aunt Bertha and Unite Us, two companies that go out into particular geographies and connect the social and human service agencies and behavioral health agencies to healthcare organizations to actually implement and deploy those services. The degree to which they're paying for them is a different matter. You look at someone like Kaiser, they're actually building housing for people who are homeless. So some of the larger players are making more significant investments. But at the very least, we're starting to see the facilitation or the referrals of those. So let's take a look at a framework that IDC created that really talks about that continuum of care. So what we did was identify 5 types of patients. To the left, preventative, stable chronic, rising risk, multiple unstable chronic conditions, and finally kind of the frail and unstable. And what we did is look across the types of capabilities that they need. So from an analytics perspective, it's really about descriptive statistics. What are the gaps in care? What kind of services do people need in terms of prevention? They might even also, deploy fitness and activity trackers, more for personal use than for detecting health issues, although we'll talk in a bit about some of the examples there as well. And then as you move to the right, you see the introduction of more devices. So for the rising risk or transitions of care, you might actually be putting devices in the home, providing virtual care, providing alerts, and providing a care manager to coordinate and manage all of those services. Then you start linking in the clinical, social, behavioral, and human services. And finally, for the frail and unstable, we're beginning to see that advanced monitoring within home care, along with additional services, patients can be managed at home, and frankly, isn't that where we want to be? So clearly this is not a cookie cutter. This is a framework that helped me in my research think about, what is it really going to take? What are the technologies and services we need to deploy to get patients the kinds of care and services they need when and where they need them? So let's move on a bit, and we'll start talking about the types of services that payers and providers are making available to both their patients in at-risk contracts as well as fee-for-service. It was really heartening to me when we were looking at the data. The data I'm going to talk about comes from an IDC survey, that providers and payers are pretty much deploying these kinds of services to both their at-risk patients as well as for patients who are still under fee-for-service. There isn't a differentiation. I think in some organizations there is that differentiation, but in general, not so much. So just to pull out a couple of data points. In terms of home care services, we see that about 15% of providers, 25% of payers are providing home care services. And at first I scratched my head and said, well, wouldn't providers be more likely to do it? But I think it's the familiarity. It's the fact that benefits by payers of payers actually include the reimbursement for those home care services, whereas providers, even if they own home care, there's less of a financial implication there. So let's take a look at post-discharge transition planning. Here we see that 42% of providers and 24% of payers. So we're talking about post-discharge transition planning. 42% of providers, 24% of payers. Makes perfect sense. That transition planning is becoming increasingly important as we want to keep people from readmitting and so forth. And then finally, behavioral health plans. 30% of providers and 22% of payers. This actually, I thought, was good news. Historically, there haven't been a lot of attention to behavioral health issues and actually developing care plans. We're beginning to see, both from a technology point of view as well as a positioning point of view, that behavioral health is really becoming much more important and needs to be managed in light of healthcare as well. So clearly we're seeing expanded services. When I first started being an analyst many years ago, all I was covering were technologies for authorizations, some case management at the high end, and discharge planning. So it's nice to see that that is moving forward. So let's talk about what are the drivers of this evolution? What's going on to make these happen? And so we came up with 4 for our discussion today. So there are changes in reimbursement. CMS is expanding remote patient monitoring. We're seeing some of the commercial carriers actually begin to provide virtual visits for their patients. And we're also seeing providers who are earning bonuses and have shared savings, putting those back into the right kind of care, regardless of whether it's being directly reimbursed or not. So we're watching value-based initiatives control costs. We're certainly seeing improvements in structure and process. Fewer people are being readmitted. People are being kept out of the emergency room. Gaps in care are getting closed. And we're just really, I think, on the cusp of taking a look at the improvements in clinical outcomes. And I think that's really part of the discussion we're having today, which is because of the barriers to access to care, you see people going to the physician getting diagnosed with diabetes, and they come back in 6 months, but no one's really checking on them or helping them meet their regime or routine in between, that lack of continuity. We're beginning to see increased reimbursement. We're also seeing in our survey nearly 24% of providers and about 31% of payers reporting they're using remote patient monitoring. One of the things that we are seeing is it's still pretty disparate. It's still pretty point. It's not really combined within a care plan for population health management, for example. We're also seeing from our data that providers are starting to use patient-generated data. And at first I kind of scratched my head. So it's about 60% of both FDA approved and consumer grade. And I thought, well, really, physicians are using consumer grade? But what we're seeing is they're kind of being used as early warning. So the Apple Watch can tell if someone's going into AFib. And while a doctor probably wouldn't base a diagnosis on that, it's better than nothing. So it's a good alerting. And we also see things like activity trackers to track ambulation after surgery and so forth. And then finally, we're beginning to see better investment in remote patient monitoring. We talked a bit about both payers and providers increasing not only the use of it, but also payers starting to be more generous in their reimbursement. So let's move on and talk about some of the attitudes of both payers and consumers as this underlying evolution of continuing to use or beginning to use remote devices to deliver that kind of on-demand care. This is from a Deloitte survey that was done, I think, in 2018. And consumers, 64%, said convenience and access were really important to them. I mean, I know myself, I get a monthly vitamin B12 shot. I used to have to go to my doctor's office, which took sometimes 2 hours between traffic and waiting and all of that. I now can, and so I stopped using it, of course. And so now I go to the Minute Clinic. It's 5 minutes away. I can make my appointment online. It takes me no time to get it done. And I'm actually being quite compliant, I must admit. And then look at physician attitudes about sort of connected virtual care. They identified 3 benefits. One is improved access to care, 66%. Improved patient satisfaction, 52%. And the notion of staying connected, that continuity of care between patients and their caregivers, regardless of who that caregiver might be. So that's at about 45%. So I think it really shows that there is a willingness, both on the part of providers, they see the benefit, and consumers, we've seen in a number of surveys, indicate that they would use virtual care or virtual visits on a regular basis. So let's drill down just a tiny bit more and talk about some survey data around medication compliance. So again, this is from the survey. And we asked payers and providers what kind of digital care coordination they were using to encourage medication adherence. We know that medication non-adherence is incredibly expensive. It leads to declining health. People have a side effect and they stop using their meds because it's not easy to get advice on what they might do differently to mitigate that particular side effect. So we see here that, oh, and I found the data point in terms of the US healthcare industry, it's estimated somewhere between 100 and 300 billion in medication non-adherence. We know that as patients age and they have more chronic conditions, there are seniors taking upwards to 10 to 15 medications over the course of the day. We also know the patients don't get their medications, their prescriptions filled. They can't pay the copay, all kinds of reasons for that. But we know that it's not good. So we're seeing devices like digital assistants, smart pill bottles, and so forth being used. And I don't think it's ubiquitous. I think once patients are identified with a compliance issue, and or if their medications and the timing of that medication is really critical, they're deploying these technologies. So it's certainly not ubiquitous. And I have to say the pill pack ads that I see are very enticing to not have to count out where and when one takes their medication. So I'm going to close my remarks to talk really about the infrastructure that's needed for healthcare organizations. And I will admit up front, I'm a data junkie. So the creation of an integrated and curated patient level data source is really critical. That digital platform needs to support both the technologies of the end user organization, technologies that they might want to use from third parties, and technologies provided by the organization that's actually creating that digital platform. Really an open platform so that we can leverage the incredible effort that it takes to create that platform, and that we can manage it in a single place, and we can govern the data, all of which the multitude of point solutions really discourage. So we need analytics to figure out which patients are in need of what kinds of services. You know, it used to be back in the day, you took the top 5% based on cost, and you try to do something with them. Well, it wasn't really useful, since some of those could have been, you know, major traumas, you know, serious cancers, things that you can't really affect the outcome of. And so we've come a long way with analytics to be able to say, not only are these people expensive today, but here's another population that's rising risk. They're going to be expensive tomorrow, and what can we do to avoid that? And then you need the workflow to create and manage those care plans. And it's not just the workflow for the care manager sitting in his or her office, it's workflow on mobile devices. It is workflow that allows the ecosystem to collaborate, that allows the communication and the sharing of data. Again, the delivery of services is beyond just clinical care. And then how do you communicate with that with the patient? Both from a campaign perspective, don't forget your flu shot this year, as well as the ability to continuously communicate with patients, to encourage them, to remind them, to provide the education they need so they can stay on the right path to get to the journey of health. And clearly that's a multi-channel capability. So I am going to close my comments and turn the microphone over to Cindy, who, unlike myself, who looks at this from a distance, is the feet on the ground and has a lot of experience in how you make all these moving parts actually work and improve the health of patients. So Cindy, it's all yours.
Thank you, Cynthia. That was a perfect foundation to start talking about scalable care management. And just for background, I know Greg shared is I've been a nurse for over 30 years. And most recently was the president of a medical group. And prior to that was the vice president for population health. So I have been those boots on the ground creating these programs, and the investment in a role as a chief nursing officer was about bringing in experience to work with the solutions. So I'm really excited to be here. So what is scalable care management? You know, as the slide says, it's a delivery model, but it's really about personalized approach based on the acuity of the patient. And one of the things that's really important to understand is that we need to start thinking about care management that goes beyond a one-to-one RN to patient relationship. That is that traditional care management. There'll always be a need for that. But care management becomes about how do we connect with a broader scope using technology, or perhaps just really guiding patients to the right services. So it's about connecting patients with resources and programs and the actions they need based on their acuity, knowing that we have patients who are at the level of really being well and working on prevention up into moderate risk, up into high risk. And that one-to-one really tends to focus more at that higher level of risk. So care management will continue to be that relationship, but it may also be directing a new diabetic to a diabetes education program that's offered in the system or in the community. It may be connecting that post-discharge patient into a remote monitoring program. It's really understanding what are your needs of your patients and being more broad in your scope of how you reach out to them. So I kind of think of it as funneling the patients to their needs and meeting their needs based on their acuity. And it's appreciating that patients are not stagnant on where they're at in the acuity scale. You can be low risk today and because of something that happens, move into the moderate risk and move back again, or you're working with high risk and you bring them down in the pyramid. And the fact is their needs change as they move up and down, and we need to have the flexibility to change and support them with that. So it's about meeting multiple levels of acuity and meeting them simultaneously. So how does Philips support this? We're going to talk about three things. One is providing insights into your care. The next is about the solutions that can support that, and then really two-way communication. So to have insights into your care, it's really about gaining insights into your patient population through risk stratification and segmentation. You can't just go out and manage a population. I had 125,000 attributed lives. I can't just manage them all at one time, but it's breaking them down to manageable parts based on their diagnosis, based on their needs, based on the level of risk, and how they're interacting or not interacting with your system. And when I say about not interacting, you may have patients who are heavy utilizers of resources, but they haven't been seen by primary care, and how do we engage with them differently? This also requires us to start thinking about managing more than just high risk. How do we start to intervene earlier in the process, and who are those patients? I mean, the traditional model has been a triggered model. So an event triggers that you're high risk. You've had admission, so you, for the next 30 days, you're at high risk. You've had 3 ED visits in 6 months. I knew one organization who said if I have 7 medications on the medication list that's been prescribed, it makes you high risk. It's event-based. It's very limiting. As hospitals, we're really good at seeing within our 4 walls and perhaps the next 30 days, but the reality is that the majority of patient care happens outside the hospital. And if we're going to partner with our patients and manage their health or to live well with chronic conditions, we need to see them where they're at and understand their needs. And what I love about segmentation and risk stratification is I can still see my high risk without a triggered event, but I can start to see who's rising risk. Patients whose risk scores have risen from last year, so we anticipate they're going to need more resources this year. Or hidden risk. Patients who have really high risk scores, but they're not really utilizing any resources. Is that because they're doing okay, or they're at time bomb waiting to go off? And then also just identifying heavy utilizers in your system who may not be triggering those traditional events we're talking about. But by having that data, it allows you to really move from being reactive based on a trigger to being proactive. And that's a very different approach to this. So what kinds of workflows or devices can help to manage this? Once you understand who your patients are and what your population looks like, a really important step here is to really do a self-assessment of what resources you already have in your system to support those populations. So you may see that you have heart failure population, but you've got maybe programs and services already in place to support them, but you didn't realize that maybe you had a large COPD population that is a heavy utilizer of the ED or of urgent care. So you can start to see that and go, oh, but I don't have something there. Understand what you have in place and really identify what's the gap of what you have in place. And so our goal here is that we don't replace those things for you, but we enhance them. Health systems often have really some great programs in place, and enhancing that can be that identifying patients who may benefit from your programs. When I was president of our medical group, we had an amazing heart failure clinic, but it really truly was the best kept secret. It was underutilized because it was dependent on really an event or something triggering someone to go, oh, wait a minute, we have some place where you can go. And, if you think about hospice programs, they're fantastic to keep primary care in the office, but they've kind of disconnected primary care from the specialists in the hospital and the programs that may be available. And counting on primary care to remember all that when the patient's in front of them, they're just going to fall short of remembering all the things that can support the patient. But imagine running a report of patients who meet the criteria perhaps for your COPD remote monitoring program, but they haven't triggered a traditional event yet, and being able to reach out to those patients proactively before they're hospitalized and say, we'd love to work with you more closely and we'd like to invite you into this program. So this is really about based on your gaps of what do you want to do, and that's where we can support you is when I start to think about what are those connected services, it could be remote monitoring. It may be a medication adherence device. It may be just care management workflows and documentation, or it could be telehealth. There are so many services that can fill in those gaps, but they have to be based on the needs of your patient. And digital communication, this is really about engaging patients in their own care. And I was excited when I heard Cynthia talk about the patient's plan of care. You know, historically, I'm a nurse. We talk about my nursing plan of care. Providers document the plan of care in their note in the office setting. But we need to start seeing this as the patient's plan of care. If we're supporting them to live well with their condition, and they have to be engaged in their plan of care and they have to own it. We need to own it with them and not own it for them. I can tell you to lose 50 pounds, but it may not be what's motivating you right now. And, you know, that basic motivation is a foundation of case management, is understanding what's driving the patient. But then how do we create that two-way communication with the patient? It's a balance of technology and personal touch. So, I mean, think about it. Even if the patient comes in every quarter to see the provider, 361 days of the year they're managing out there without us. So how do we help them to have that plan of care and give them access? In our longitudinal plan of care, we give them access. This is your plan of care of what you've agreed to work on. And they can see it. They can see how they're performing on it. We can see it, and we can use it with discussions for them. But there are items that they've agreed to. And then, again, I'm just going to point out remote monitoring is a form of communication. And, again, it's not just about the patient's vital signs coming to us so we can see what's going on. It's so that they can see, oh, if I have a goal to maintain my blood pressure, I have a goal to lose weight, how am I doing with it? And I'm tracking and allowing them to communicate with us in a way that they're comfortable with, which might be a chat, it might be a email, and it may be a traditional phone call, but it's giving them access to their care team, and we're monitoring that together. And Cynthia touched on this, which is incorporating that patient-reported outcomes. This is the ability to utilize surveys through technology to get direct feedback from the patient. And there's huge value in that. So we utilize surveys to, you know, if a patient has been in to see you because they have heart failure and is sending them a survey 3 months later asking them how their symptoms are. It's having that connection and that ability to have eyes beyond, vision beyond the visit to their ongoing care. And so how are you doing? And being able to proactively bring them in if there's an issue. It may be inviting the patients to participate in a program because they, the segmentation and the risk stratification showed they could benefit from it. But it's also an amazing way to take some of that workload off of the office visit because you can do depression screening through this. You can do fall risk screening. We all have to do depression screening on every patient 14 years and older every year. Well, our challenge is how do we get them all in? Perhaps it's how do we get a survey to them, which is very easy to do, and it comes back, and it will, if it's positive as a PHQ-2, it can trigger a PHQ-9. And then you get the positive results back, and you act on those, but you have a depression screen of everybody you send it out to. So it can really help with, again, those gaps in care and that compliance. It won't do away with all the letters or all the phone calls that we have to do, but it is about opening up new ways of communication and engaging with the patient, allowing us really to support them throughout the year and not just go, well, we had a visit, I hope the next 6 months go well for them, but using technology to stay connected to them and using technology to expand our vision of them without always having it be the front desk who has to make that phone call, because frankly, our front desks have enough to do with the greeting and the exiting and the checking, the validating IDs and insurances. We need to use technology and offload that and allow us to intervene. Imagine getting a phone call that says, hey, how are you doing? Because I noticed that perhaps your symptom survey, I noticed that you're struggling with your breathing, with your COPD. Maybe it's time to come in and let us check you out. That's pretty powerful for a patient to get a phone call like that and know that you're there and you're still with them even when it's been 3 months since your visit. So if we go to the next slide, this is what we call I've really been talking this whole time about our connected ecosystem. And just a few things I want to point out here. When I talk about data aggregation, risk stratification, segmentation, we call that care exploration. And what's really important here is that it's bringing your data together so that your data is actionable. And that's what's really important. We have that ability to bring in the data from your EMR, from your multiple EMRs, oftentimes in health systems. I have worked with a few health systems that have 25 platforms, but also bringing in the data from all those platforms, from your health plans, from your regional labs, from your financial databases, your HIEs, and putting it all together, normalizing it so it's all speaking the same language, and then risk stratifying, segmenting. It's not an EMR, but it does create a longitudinal record for the patient, and having it create that allows us to look at the individual patient, but it also allows you then to aggregate it into perhaps a provider's populate panel, or a practice's population, or the entire medical group. It's that ability to see the entire picture, because with that health plan data in there, you're seeing the activity that occurs outside of your health system. Some of the strengths of this is that it doesn't require you to change your EMR, which is not practical in the world we live in. We've invested far too much in them. And as we start to talk about, we keep folding in new medical groups and new practices, or this clinically integrated network working with this one, you want to be able to measure across that and work together. And the health plan data would be the third key one here, which is it's an incredible source of information, but it's really kind of a mess to work with. It's challenging. If you wait for the aggregated reports, which can be helpful, they're 6 to 9 months old. Getting that data monthly, getting the raw data is what you need, but there's thousands of lines of raw data, and none of them are structured the same. So being able to bring that into a system that can make sense of it, and so you can then measure what you're doing and see how your performance is what you need to have eyes on. Because really, I kind of think of this as a bookend. You've got that care exploration at one and analytics. And analytics is the ability then to measure how successful were you at what you did. We need to get savvy at this. We need to have a responsibility if we implement remote monitoring. What were our outcomes for that remote monitoring patient versus perhaps the patients who were not remote monitored? Or what's the before and after of that? Having the ability to measure your PMPM, your avoidable ER utilization, your cost for your pharmacy, having that health plan data, you can then measure that. And that's that bookend. And in between that's all where we take action and address the patient needs. So if we go on to the next slide, this is just really a visualization, and I love this, of the acuity of our patients across, from low acuity at the left to high acuity at the right. And as Cynthia said, we're kind of used to, you can peel off that red at the top and get very focused there, and we are. I mean, across the country, people are trying to manage their high-risk populations. But if that's all you manage, you do good work, but it also can feel a bit like a hamster wheel where you're just constantly churning through that. And I think our challenge is, how do we start to take action at the lower acuity and the mid acuity and prevent patients from moving into the red or pull them back into the orange, and helping patients to live further down in that scale where the resources are used more effectively. And that really is the challenge we're talking about today. So what I want to do is talk about two patients. And the first patient we're going to talk about is Albert. And Albert is 74. He's widowed. He lives on his own. He has family who supports him, but they're not in the immediate area. He's been having some dizzy spells, and he's worried about him. And if he's really honest, he's not always good about remembering his medications. he's kind of worried about falling, and he's going to be alone, and there's going to be nobody there to help him. But he's a little intimidated by technology. What the care team did here is the care team they meet with Albert. They make sure Albert includes his daughter Maria, because she is his support. We want to make sure she understands, but really talks through his challenges. And what they decide on is that we're going to implement a home blood pressure monitor for him, and we're going to do medication adherence device and then patient emergency response device. So this is meeting a few needs for Albert. One is getting blood pressure and having that come into his care team on whatever frequency they decide, is that they can start to see what's going on with his blood pressure. And they can have flags that will alert them when there's significant changes that they may need to address. A medication adherence device, we call that Spencer, will alert Albert that it's time to take his medications and dispense it to him. It will also track if he doesn't take the medication. And it can track his using surveys, how he's feeling when he takes his medications. And the alert system is Lifeline. You wear it around your neck, and it gives him 24/7 access to a team that's there should he feel dizzy, should he fall, which we hope he won't fall, but if he's feeling dizzy, he can call and just talk to them and work through this. But they will also communicate with the care team based on his utilization and what's going on, his activity, and they have some great predictive analytics that can tell the care team that perhaps his probability of being admitted to the hospital has gone up over the next 30 days. So what we do is we will send in a tech person to meet with Albert and Maria to go over his technology, because he's a little intimidated by it. We're going to teach him how to do the blood pressure. We're going to have a pharmacist review his medications and see if there's any changes recommended based on his dizziness, and that medication alert device. Because his driver in this, and you always want to get to his motivator, he wants to stay at home and he wants to be independent, but he's going to need some support. And this is a challenging place for the physician practice, because they can't be there for him every day calling him. They can't be there for him every day checking on him with a phone call or to touch base. But with these devices, what they have is, through protocols and real management, they're virtually there with him. And they can use the electronic systems to alert them when there's been changes to Albert. So then we reach out and, Albert, how are you doing? So it is connecting to and expanding our ability to stay connected with our patients over time in a different way. And the real beauty of this is that for Albert, all of these devices work off of one application. So he just has to learn the technology in one application, and it works together. And him and his daughter can view how he's doing. And it's not about him using 3 different apps, because it's 3 different devices. All the devices can work off the same app. But acuity, and managing an acuity and scalable care management, isn't just about our elderly, and it's not just about our higher risk. And I want to talk to you about Juan now. Juan is 48 years old, and Juan lives alone, and until recently, he's not experienced any major health issues. He's got some nagging knee pain in his right knee. Other than that, he feels really good. But his team, through the risk stratification and the segmentation, identified him as a patient in the low risk, but he hasn't been in more than a year. So they'd reached out to them to have him come in for a visit. When he came in, he was kind of surprised when he got on that scale that none of us want to get on, that he's gained more weight than he had thought, and he's really gotten to the level of having an unhealthy BMI, and his hemoglobin A1C is a little elevated. So for Juan, he's become pre-diabetic, and the practice wants him to not be pre-diabetic. They want to move him back away from that, because you can still intervene at this point. But in talking to him, his motivator for change and changing his lifestyle, his eating, his sedentary lifestyle, isn't the potential of becoming diabetic. It's his knee pain. He really wants to feel good again. So again, it was working with a care manager in the clinic, and after talking with him and knowing that his motivation is the knee pain, he wanted to really have education on nutrition and exercise, and he agreed to have a blood pressure scale at home to really help him to stay accountable to this process, which he gets on every day, and it automatically records his blood pressure to his care plan, where he can get on and see it and track how he's doing. His care manager can see it, and when they have phone calls to do a phone visit, they're actually using his data real time, and he hasn't had to record it himself. It's just gone through. And after 6 months of doing this, his weight has decreased. He's lost 25 pounds. His hemoglobin A1C is reduced, and he feels really pretty confident that he can do this himself. And the scale leaves, and he really moves down in that acuity and does more self-management at that point. So it's just, again, an example of thinking about the ability to do case management beyond utilizing technology to support expanding our scope. So if we go to the next slide, we put this in here just so you can see, and we've talked a lot about remote monitoring today. The statistics really show that it does make a difference, that it can reduce hemoglobin A1Cs, that it can reduce BMIs, that we can prevent readmissions and hospitalizations. And they're demonstrated in the results that we see with patients. And if we go to the last slide, it really is, people will say, well, where do I get started? Do I get started with technology, organizationally, clinically? There's not a right or wrong to that. What I would say is, from a technology perspective, if it were the priority for me, I would say it's having that ability to risk stratify and segment your population so that you get to manageable components that you can start to address. Because even organizationally, you can't just go into your C-suite and say, here's population health, let's do it. That's a little overwhelming. But if I can go in and say, I'd like to try this with this population, pick a population and start. And you have to measure the effectiveness of it and define what the ROI is ahead of time. And you may have to get creative. It may be about, we're going to reduce the PMPM. We're going to reduce ED utilization. ED utilization isn't necessarily, it's not going to be a revenue enhancer for the organization, but you can show that it's going to improve your PMPM, which will improve your contracting ability. You have to get a little creative sometimes to show the CFO the difference that's going to make, but you can do that. And then hold yourself with analytics accountable to measuring that on that monthly basis so that you're able to make changes as you go, or you're able to say, this doesn't work, let's shift. But, a pilot is meant to be piloted and to try it. And too often I see a pilot gets put into place. We don't have good measurements. A year later, it's really not a pilot anymore. It's become how you do it. So let's try early. Let's fail fast. Let's be willing to make changes as we go, but measuring, that's really important. And clinically, let your data drive you to where you need to focus. Oftentimes we look at what's popular in the literature. Heart failure is everywhere, and should we be managing heart failure? And you may have some great heart failure stuff going on, and your segmentation and risk stratification perhaps shows that you're doing really well with them, but that you need to focus on COPD or diabetes or perhaps knee replacement. It can be any number of populations, but let your data drive you to where you can impact, because again, you want to be able to show that what you did made a difference. So with that, I'd really like, Cynthia and I'd like to open it up to questions and see if there's anything we can answer for you.
Yes, hello, Greg back. Let's go ahead and go through a few of our questions. Cynthia, first question for you. You spoke a lot and showed some surveys around connected virtual care and buy-in for that. Did you also take a look or any insights as well as where virtual care has been impacting workflows, both for providers and staff, and how that mix is being managed as well?
Good question. In terms of workflow, I think I mentioned when I was talking earlier that a lot of the remote devices are kind of random, and I don't mean that pejoratively, point solutions. And to Cindy's point, you have to go multiple places to get the data and to coordinate the efforts. So the impact on workflow today, I think, is pretty heavy because you have to go to multiple places. And as we all know, we want to stay in a single application. And so, you know, as Cindy was saying, once you have that digital data platform, you can manage those devices in a single place. So that reduces the impact on workflow and kind of eases the burden of having to, you know, do the chair swivel to multiple different applications to get the data. So I think the key to managing the workflow or creating manageable workflow is that centralized digital platform that we talked about.
Yeah, I would add also, I'll put my policy hat on for a minute too, and I would add also, you talked about RPM fees, you talked about a lot of new things that are in the physician fee schedule, virtual ecosystem, things like that. A lot of times, some of that workflow is going to be dictated, might be a strong word, but there are requirements as well. If you look at those RPM codes, there's 3 new codes. 2 of them can be billed by the practice. 1 of them cannot. It cannot be billed incident 2. Your provider, your physician has got to get in the mix, look at alerts, look at interventions. The other 2 staff can do. So a lot of times when you're looking at fees and looking at billing, there's going to be some workflow determinants done for you as well. That's where you start looking in the fine print on some of these codes and some of these reimbursements too. So it's something to keep in mind also.
And Greg, this is Cindy, I would just add to that is that from an operational perspective, it's realizing that you do need to think about that workflow on the ground with it. And I know one of the things we did was identify, you know, what provider would be doing virtual visits for the day and really giving them protected time to do that, as opposed to just trying to squeeze it in between visits. It was, you have to think about how do you create that space for a provider to do that.
Yeah, it's not an oh by the way activity. It's really neat. You need that dedicated resource. I think that's a good point from an operations perspective.
That all makes sense. Another question here, Cindy, directed to you, but I dare say you could both weigh in on this one as well. In speaking about care management, where would you implement an initiative first? In terms of a list of either conditions or what clinical relevancy, where would you start, so to speak? And then at the same time, what care management services do you think have the potential for the greatest speed to value? So a bit of a 2-part there.
So if I didn't have something in place and I was going to start, I would start with focusing on transitions of care. You know, one of the things that was one of the early projects we did, and you can have that connection to a patient within, we would contact the patient within 48 hours of going home, can make a huge difference in what happens in that first week, because you can identify a lot of issues going on and prevent readmissions. And we found that our readmission rate was much lower when they had a transition of care work being done versus not. So it would be, if you could do nothing else, it would be having a care manager who's doing transition of care phone calls and follow up. From a quickest to see, and I think you can see a lot of quick reward with that. From a technology perspective, when I look at all the technologies available today, I think remote patient monitoring has some of the greatest potential in that 30, 60, 90 day of that acute period of really managing the patient and then really moving it to the next level, which is at all year long at a lower level of need. But I think if you want quick impact, it gives you scope to manage that transition of care with just an RN. You have limited what you can do in a day. Remote patient monitoring really gives you the ability to manage much more.
Yeah, and I think it's one of the more mature technologies. I mean, I can remember back, gosh, 10 or 15 years ago, I was an analyst, and the first, I can't remember what it was called, but it was a big box that you pressed different keys in response to a set of questions every morning. And so I think there's a level of comfort with remote patient monitoring. And it's not as intimidating or as overwhelming, perhaps, to a larger set of patients as maybe doing something on a mobile device that you may not be able to see it as well, you may not be familiar with it. So I think I would agree with Cindy that remote patient monitoring, because of the maturity, because we're starting to see some reimbursement for it, and a comfort level by a larger percentage of the population and the breadth of what can be monitored, frankly.
Yeah, it's pretty
Thank
easy
you.
to implement.
Yeah.
Yeah, thank you. Thank you for that. More questions coming in. I would say whichever one of you two want to jump into this one. Probably going to hit you, Cindy, in your experience on the ground. At our practice, our need is not necessarily feeds from patient devices. It's sending information from our population health division to the primary care provider's multiple EHR platforms. Can you do that? How much information can be transmitted? End of question.
It's a great question, and it's an important one. What I would say is it absolutely can be a two-way feed of bringing information back into the EMR. I would say the challenge, which is fantastic if you can do that, bringing in patient-reported outcomes and how they're doing between visits. I would say the limitation with that right now is oftentimes is the IT department and the policies they have, meaning I know organizations who bring it in and they love having it in, and then there are IT departments where it's a much more conservative approach of, well, we don't want that data in because it's not validated, we didn't measure it, it came from the patient. And so I've seen it done both ways. Can the technology do that? Can it feed it back to the EMR? Absolutely. But it really will be, I think your biggest challenge will be your own IT department and what level of comfort they have with bringing that in. But can it be done? Absolutely.
Yeah, I think there's another consideration which I see a lot of, which is how much of that remote data do you want in the EMR, right? Do you really want to load all that in, or do you want some way to access that data from the EMR, and then based on whatever criteria is set up, bring that in based on it's a really important piece of data about this patient, or no, it's not so important. I needed to know that they're stable, but I don't need to have their blood pressure reading from every day. So I think there's an interim step of not necessarily housing it in the EMR, but having the EMR be able to access that data and then be able to make more discrete decisions. And we're certainly seeing technology that allows that to occur. So the care manager, the physician doesn't have to leave their native workflow, but they still can access the data. So I think that's another approach.
And I agree completely, Cynthia. And how I see most people do it is not bring it all in, but when there's a flag that they're going to take action on, they'll document that in the EMR. So it really does limit that. So it really can be done both ways.
Yeah, good point.
Mm-hmm. Yeah, let's do one more because we've got a minute or so, and we have another question come in that really looks like variation on a theme here. Let me read this one off, and y'all can just jump in as you will. In addition to aggregating data from disparate EMRs and other tools, how do Philips and other vendors approach incorporating near real-time data to surface hospitalizations and readmissions to hospitals? I think this is another variation over on RPM and how that data can flow.
So the key with that is your HIE. I came to Philips from Michigan, and in Michigan we have 6 HIEs, and they have worked hard to at the HIE level as became kind of a super HIE that brought admission data and ER data together, but it was you could get it, but it was having the ability to bring it electronically. And what we did was, yes, we can do that. We had those feeds come into, we were using Philips Wellcentive, and that HI feed came in pretty much real time. if one of our, and it gave us the ability to see patients who hit the ED or hit a hospital within Michigan that was outside of our system, because we could always see it when it was in our own system. It's when they're, you know, they're at U of M and I didn't know they're at U of M and they're in the ED. So yeah, we brought those alerts in, and what we did was we created it so that feed came into Wellcentive. It didn't feed as well into our EMR. Our EMR was a little bit more restrictive about some of those feeds. We brought that feed into Wellcentive, and then we had it create a kind of a work list for the care manager that they could go in and they have an alert that the patient had been admitted, and they could see it based on the practice that the patient belonged to, so that they could follow up with the provider or follow up with the patient as needed. So it's, again, when we talk about that ability to aggregate your data, we can bring that data in from the HIE and feed it into a spot where it's workable and actionable for you.
Yeah, and I think it's a really important point, which is there's latency in the traditional data that we bring in for analysis. And I've actually heard of instances where a large integrated delivery system, you know, was within an HIE state that was pulling in the ED and admission data, and they were actually picking up the phone to the emergency room of a hospital outside the system and saying, "Why is Cynthia there? And can we send an Uber for her to get her to her doctor's office?" You know, so really proactive management that really had a huge impact, because you're catching the horse before the horse is out of the barn. And so I think any vendor in the population health management market that's not able to bring in real or near real time data, assuming that data is available and you can get access to it, is going to limit that really early impact, which can have a huge effect. I mean, you know, you walk into an emergency room and no one diverts you. God knows what the bill is going to be like, because every test in the book is going to be run on you. So I think it's really a critical capability that you want to look for.
Oh, thank you for that. Gosh, I feel like we could just keep going, but at 3:03 Eastern, we will go ahead and end. Thank you, attendees. If we did not get to your question, we will get you out a written response along with all the materials we will send out to you. Thank you again to Cynthia and Cindy, to our speakers. Thank you all for attending, and keep an eye out for our next webinar.